Well, good afternoon, everyone. My name is Jamie Schrant. I'm the Director of Outreach for Rogers Behavioral Health, and I will be your moderator today. Joining me today is Dr. Marty Franklin. He's the Clinical Director at Rogers Philly location, and he's here to talk about current research on telehealth compared to in-person treatment for children with OCD and anxiety. Welcome, Marty.
Well, thank you.
Just go ahead. I was just going to say, for everyone who's joining us today, I am going to start off with just an overview, a quick overview of the format that we have here today. The webinar is scheduled for 90 minutes. And to receive CE credits, you must be logged into the webinar for the entire program. There's no need to check in via chat. Your attendance is tracked via the Zoom login record, so no need to check in. In addition, a PDF of the PowerPoint slides and a list of references will be made available immediately after the program via an email with a link to your personal dashboard on ce-go.com. In addition, a recording of this webinar will be published on the resources section of our website. It will be published there within a next day or two, so please, if you'd like to rewatch, just go there. Our speaker will give a 70 to 75 minute presentation today, so Dr. Franklin is going to be speaking for 70 to 75 minutes. Following that, I will facilitate a Q&A session. So you'll note again that we have deactivated the chat feature. We've found it's been a distraction to the presenter and other participants. But if you would like to ask a question, please use the Q&A button, not the chat button, and just send me a message that way. At the bottom of your screen, you can simply click on the Q&A button on the Zoom taskbar. I will review the questions that are submitted, and then our presenter will address them during the Q&A portion of this webinar. Finally, we have enabled closed captioning for this program. At the bottom of your screen, there is a live transcription button. From that menu, you can click Show Subtitles to view the audio as text. If you'd like to disable the subtitles, simply click Hide Subtitles from the live transcription menu. So without further ado, I'm going to hand it over to Dr. Franklin. Dr. Franklin?
All righty, thank you. Let me see if my slides are moving too. Yay. So I'm going to be talking about CBT Telehealth for Pediatric OCD. Just so happened to occur during COVID-19. I'll explain that all. And we have a matched in-person treated sample that we'll be comparing our outcomes to, try to benchmark this a bit. I'm going to start off by telling you a little story, which is the last time that I did a webinar for Rogers. It was for another very large group that I can't see. So it's a bit of an odd interpersonal process. And so my son and I were sitting at breakfast, and he asked me, he said, what's the difference between doing one of these presentations in person versus doing them online? And I said, and I was completely serious, I said, the biggest problem for me, it's the same content, but the biggest problem for me is when I make a joke, I can't see anybody laughing. And he paused. He's very good comic timing. And his response was, but Dad, how is that any different than when you present in person? So I will start with Ted's reminder that there might be people enjoying the humor, but I can't tell. So this is what I'm going to do. And we have Q&A at the end, and I'm perfectly happy to entertain questions at the back end of this. I don't have any financial relationships to disclose. And what I hope to accomplish is that we're going to talk about the essential components of CBT for OCD in kids, And we're also going to talk about the potential value of telehealth treatments in mitigating some crucial barriers, at least two that we can think of, in access to care. I think this is going to open some doors, and the outcome data will hopefully convince everybody that this is an avenue worth pursuing. So we'll talk first about the rationale for telehealth and whatever data we have on efficacy. We'll then talk about the details of the current study, talk about clinical implications and what's next, and then the moderated Q&A will follow. So let's start with the telehealth rationale and efficacy. And first, I will say that the paper that this entire talk is been turned into a paper, and we're actively and eagerly looking forward to response from the journal we submitted it to. This process is difficult, and what I would say is the editor of the journal we sent this to immediately told me that there's an 87% rejection rate. He was trying to remind me that this was not an easy process, and I let him know that I'd been through it before, and I'm familiar with this process, and I'm willing to take the risk anyway because we think this is important work and we think people should know about it. So hopefully, because sometime by Christmas, I should have an answer. So what do we know about telehealth in psychiatry and psychology? We've actually got a decent amount in the last 20 years. There's been a decent amount of research done. So there's certainly in depression and substance abuse and even PTSD, we've got some adult work that suggests that the telehealth options are both preferred and viable and efficacious. In adults and OCD, we also have quite a number of studies now over the last 10 years or so. And more recently, we've moved into trying this with kids and teens. Those John Comer papers or papers I was on for the treatment of little kids. So a lot of it was targeting parents. And Lenhard et al. Is a group in Sweden that's done really important work in telehealth across the anxiety disorders, including OCD. And Eric Storch also did what they call the webcam study back in 2011 that helped open this door for another possibility, another way to reach families that have kids who are suffering and having some trouble with access to care. So that's what we knew. So we're thinking about it, and certainly it's an avenue for care, especially when access is limited by distance and travel. If you're 6 hours away from the closest clinic, it might be easier for you to do this tele. There's also issues about time and expense. It's expensive. You have to take, if you're a parent, you have to take a half a day off from work to come to the clinic. It's often an hour commute to get there, an hour visit, and then an hour home. So it's disruptive. And there aren't that many therapists, so it also might be the case that this will be another way to make this easier to do. Questions I think that have been lingering are who does this work for, but maybe more importantly, who does it not work for? So I'm going to try telehealth. Are there folks who've got characteristics that make telehealth less likely to work for them? That's a group I want to be able to identify. And as I said, over the last decade or so, there's been some work going on here. There's certainly clinical application and now the research following it. And it was all sort of going on in the background until the world changed. So COVID-19 and its clinical implications. The problem, of course, is that the rising tide raises all boats. So anxiety and depression is more likely to go up when you're socially isolated, and there's a lot of anxiety in the air, among other things in the air, that are driving fear and driving worry and driving concern about your personal health and safety, your family's health and safety, the implications for the economy, et cetera. There's a lot of anxiety out there, and we know that those rates went up. OCD, if you had OCD when this started, this probably reinforced some of your fears and probably reminded other folks that maybe you were not entirely wrong about being worried about certain things. We had a problem with therapist unavailability. Therapy offices closed in March of 2020. We had about a week to pivot. and we were going to close all of our in-person services, and we need to pivot to something else because the alternative was much worse, which is pivoting to nothing. We didn't feel that was a responsible thing to do. So we prepared in advance, knowing it was coming. And within about a week or two, we were up providing virtual treatment. Patient reluctance. Patients didn't want to come. And if you talk about OCD patients, they really didn't want to come. So we had an immediate need to shift to virtual platforms to at least continue to provide the care. So that's kind of where this idea came from and was fueled by. Now, there are a number of things that grew during the pandemic. And I would say the rates of anxiety and depression in the general population went up. If you had OCD or you had anxiety or you had depression before the pandemic, you were more vulnerable to an increase. That's what the CDC tells us. We also know demand for mental health services across the developmental spectrum went up. All of a sudden, kids were home because they weren't in school, and maybe their symptoms are more evident. Maybe they're more functionally impairing. So families got more interested in seeking the help. And what really came is the need to study delivery methods to determine their long-term viability. So we're giving the treatments remotely. We're using telehealth to try to provide clinical care, but we don't have enough information about how well it works, who it works for, who it doesn't work for. And so we needed to build this bridge to look at it. And that's we saw an opportunity here, and we took advantage of that opportunity. Now, regarding the prior picture, there was some debate at home. I was of the impression that I looked like Brett Kiesel, the former defensive lineman for the Pittsburgh Steelers. My wife was asking me if I was trying out for a ZZ Top cover band. And my kids all decided that I looked like a common garden gnome and started to bring me pointy hats. I finally got the beard under control after taking a little bit too much heat. So, but suffice it to say, we had an opportunity, we want to take advantage of it, and this is what we did. So COVID necessitated this pivot clinically. And the clinical pivot meant we had large samples of people receiving telehealth services that were usually done in person. We had protocols developed, we had trained staff, we were in a good position to make that comparison. How well does telehealth do relative to what we would customarily provide in person at a higher level of care? All of the treatment trials I showed you before were done at outpatient levels of care, weekly treatment. So this is another question that we needed to answer is how well does this work at the higher levels of care? We're talking about 3 hours, 6 hours a day of being online and with kids. So that wasn't necessarily an easily answered question. We thought we wanted to look at it. The large samples available at Rogers afforded us the chance to look at things like response to treatment, predictors of treatment response, moderators of outcome, the kinds of things that are often sought after in treatment trials, but you don't have the sample sizes to do it. At Rogers, we have the sample sizes to do it, which I'll show you later. And the matching procedure allows us to compare outcomes from people treated in tele to people treated in person by our staff. So a little bit of experimental control, if you will, to see how well we do with telehealth. And the real world implications, especially at higher levels of care, this is really an open question, is can you do telehealth at a higher level of care, IOP, intensive outpatient, or partial hospitalization that's comparable to what you would get at and outcomes you would achieve in-person treatment. Let me walk you through a little bit of this. We published, I think this is out now, the Farhat paper, a meta-analysis and review in which we collapsed samples and wound up with a sample of 1,234 patients, pediatric OCD patients, which was by far, it's a meta-analysis. It's across multiple studies, the largest ever seen in the literature. Individual trials range from 67, 70 patients up to the largest ever published to this point, which was the Nordlots trial, a multi-site study done in Norway, Sweden, and Denmark. I was part of that trial, and we published in 2015, and we were looking at CBT outcomes and then adding sertraline for partial responders. And we had 269 patients enter the trial in person. These are all in-person trials. These are all customarily done at the level of once a week treatment. And you can see there's many of these decent sized samples, but not the kinds that we're going to show you in a minute. So this is the current study. One of the reasons we're excited about it is because when the larger the sample size, the more confident you can be about what you're seeing. And the larger the sample size, the more fancy math you can use to look at these predictors of outcome, which are very important, really looking for who responds and who doesn't. So in this sample, we have, bringing down to the bottom, 1,286 kids and adolescents with OCD. By far, the largest treated sample of kids with OCD that's ever been seen. Not published yet, as I mentioned, but it's under review. And what I would say here is this is almost 3.5 times larger than the Nordlots trial, which was the largest ever done before, and that was double whatever else had been out there. So with that, we had 643 patients we treated via telehealth after June 2020, when we had pivoted to data collection and all treatment virtual throughout the Rogers system. This is a multi-site effort, and the data team at Rogers makes this stuff so much easier. Brian Kay is our lead there and done incredible work to make this sort of thing possible. And we're talking about doing this in a month's time, pivoting from having no such thing to now having it available to us. So 2/3 of the sample that we saw was female. And I would say that the data on race are a little bit tricky. So 69% identified as Caucasian, 20% didn't disclose. So 10% did disclose as being non-Caucasian. I think the reality, though, of our samples is that probably the vast majority of those who didn't disclose are also Caucasian. So I'm thinking that it's not unreasonable to assume that we have about a 90% Caucasian sample. We have African American, we have Hispanic, and we have Asian American as well. In large enough numbers, percentage-wise, no, it's 10% of the entire sample. But numbers-wise, we have enough to start looking at response by race and ethnicity, which is going to be really exciting to look at. So 643 patients got telehealth, and we matched to an existing sample of 643 matched controls who were treated after September of 2015, when we automated all this data collection. That was a little bit more of a male sample, so 55% instead of 67% female. And I think the data I was just mentioning about race, ethnicity, I think they're about the same, roughly 90 in both. And so we have an average age, which I think is interesting. If you sampled us before, it would have been younger. We have an average age of about 14.1 of this sample, which is the telehealth sample, then with a matched sample. And I think that's older because there were some clinical decisions made that if I have a 9-year-old who's climbing the bookcase, that maybe telehealth isn't the best way to do this. So they weren't, clinically, they weren't entered into the trial. We do have some younger kids. We're some, full range is 7 to 17, but I would say that there were a lot fewer kids in that younger range, which is reflected in that number of 14 on average. With a little bit of an older sample, more of an adolescent sample, I guess the way I put it, because we thought they'd be able to manage this. So the measures we used, the Cybox, which is a primary outcome measure in every OCD study in adults and kids done in the last 30 years. Its range is 0 to 40. I'll walk you through that once we start looking at data. And we've done some studies. We use a self-report version instead of an interview measure. Self-report has been comparable to clinician rated at Rogers, and we were feeling better about that, although it still is a gap, which we'll talk about. We use the responder and remission criteria from the Cybox that we generated out of that FARHAT study in the Orange Journal, Journal of the American Academy of Child and Adolescent Psychiatry. Now no longer in press, it's out. And the PQ-LESQ. So we know that when you're treating OCD, that's the primary target, but we also know that quality of life can be affected, and your treatments ought to have some impact on quality of life. So it's a quality of life measure that we used before, and it's a relatively short scale, and we employed it here in this trial as well. So we're looking at, really the main issue is remote treatment. How does remote treatment do? If you got assigned to remote, not assigned, but if you happen to get remote treatment during the pandemic, how did you do relative to a matched sample of kids who were treated in person? We're looking at other things like whether you got your treatment in partial hospitalization or intensive outpatient, partial being 6 hours a day, intensive outpatient being 3. Looking at age, looking at how long you were with us, looking at gender, looking at race and ethnicity, also insurer payer types, and also number of diagnoses. So if you came in with OCD, customarily, I'd say the kids we see come in with more than one diagnosis and sometimes more than 2. So did that matter in terms of implications? I won't bore you with the statistical stuff here, trimming models. Suffice it to say that if a predictor wasn't useful, it was dropped. So let's talk a little bit about the multimodal levels of care. I'd say, again, the literature is built on weekly treatment. And I'd say that with pediatric OCD, that's even more true than it is in adult. It's customarily a week, 12 weeks, 14 weeks of weekly treatment, cognitive behavioral intervention, including exposure plus response prevention. But we know from having done that for a very long time, both research-wise and also clinically, there's some folks who don't respond well at that lower level of care. If you think about it, if I ask you to do a homework assignment on Friday and you come back in a week and you haven't done it or it didn't go well, an entire week just went by between me being able to modify that or help you with that and the passage of time. So it might be there's some folks who need a higher level of care, more support, more ancillary services that we can't provide in an hour in weekly outpatient treatment. So we step folks up. And I think Brad Riemann talks about this a lot when he's presenting, and talks about it as, I'm just trying to increase the dose. If this were a medicine and I gave you a low dose and I had range on that dose I could get to, I probably want to raise your dose before I conclude that the medicine doesn't work. So that's what we did here. IOP, as I said, I'll talk about it in a little bit more detail later, but IOP and partial hospitalization. Now note, we didn't sample anybody from the residential programs for this, so we're really talking about higher levels of care, but not the highest level of care for this sample. I'll get to that at the end. So what are the 4 essential components of cognitive behavior therapy for OCD in kids? These are sort of, I mean, there's lots of other things you can include, but this is the guts of it. Exposure in vivo, so prolonged confrontation with anxiety evoking stimuli. If you're afraid of contamination, I got to get you to touch stuff that's contaminated. If you're trying to do that in the middle of a pandemic, you got to make some modifications, as you can understand readily. But it doesn't change the truth. I mean, I think that when Dr. Fauci was on regularly reminding us that you come home and you wash your hands for 20 seconds, you don't need scalding water, you stop after 20 seconds. Now, once you're in your own private domain, all bets are off. There's no reason to continually be washing. And I like to remind people that the way I think about this and try to get my patients to think about it is you follow the CDC, not the OCD. So this is what the CDC says. We're not telling people to not ever wash. We made some modifications there in light of the pandemic, but you don't need to wash 65 times a day. I had a patient once tell me, an adult patient, that he's following the CDC guidelines. And when I asked him how many times a day he was washing, his answer was either 50 or 60, depending on the day. And I've scoured the CDC guidelines. I don't see that in the CDC guidelines. I think it was His fear was driving the possibility that he might have accidentally touched something that he didn't wash off, so he better wash it off again. And that's garden variety OCD, and we got to confront that. And you confront it via in vivo exposure. You can also use imaginal exposure. Imaginal exposure is very helpful if some of the things the patients are afraid of are hard to do practically. So if I have one of those folks who's afraid of running somebody over with their car, we do go driving with them. We encourage them to go driving without ritualizing. But to confront the fear of having killed somebody while driving, we don't drive on the sidewalk. What we do instead is we do stories of driving, losing control, hitting somebody, getting arrested, etc. Wherever that person's story takes you is where you go. That's imaginal exposure. Script writing, basically. Write a horrifying script, read it again, read it some more. Continue to read it, and then over time, that the imagining that event will come with less power, and then you'll be better able to push through it. That's the concept. I can recall that my son, kind kid that he is, he sat behind his mother when we were all watching the movie It, and when he sat behind his mother, he was telling her in advance when the jump scares were coming, because he'd seen the movie about 20 times and she had not seen it at all. And I think that probably assisted her in enjoying the movie and not wishing to leave the room. So in some ways, his exposure work helped her. Response prevention is the blocking of compulsions, and I don't really mean blocking. What I mean more is encouragement to refrain. So education about refraining, encouraging to refrain. I don't stop people. I don't tackle folks at the sink. That's not going to be sustainable. It's got to be a voluntary choice. I teach you why it's important. I try to encourage you to do that. And ultimately, what we're trying to get to is reduce and ultimately eliminate your compulsions. You're not going to be able to eliminate them on day one, or maybe you wouldn't need us, especially at the higher level of care. I'm going to have to do that gradually, but ultimately, I want you to be able, if you're afraid the stove's going to blow up, I need you to be able to use the stove, leave the kitchen without checking to see if it's on, go sit in the next room, go sit outside the house, and let's find out. Let experience tell us what's going to happen. That's response prevention. And we know from studies, really good study done in the mid-'80s by FOA and colleagues, is if you just do exposure without response prevention, or you just do response prevention without exposure, neither one of those treatments works as well as doing both together. You need both. And the cognitive methods we talk about is in the middle of exposure or after an exposure, patients have ideas about what's going to happen. And exposure provides you with opportunities to confront that. And so I'm going to be asking people, all the time, I ask people, what do you make of that? We just touched this contaminated surface and you said we'd be sick in 15 minutes and it's been 40 minutes and I feel fine. How about you? I feel fine. Okay. What do you make of that? And we start to ask questions about whether OCD is telling you the truth or not. So these are all important, pivotal pieces of this treatment. I think this is a cognitive intervention in the sense that we're trying to change cognition, but we try to change cognition mainly by changing behavior. And then when you change your behavior, we get to check in on your cognition. You said this would happen. Why didn't it? What do you make of that? So we got treatment hierarchies. We know that OCD can be sort of flexible, if you will. And the way I look at it is it's like Hawaii. OCD is like Hawaii in that there's usually more than one obsessional theme. And every one of these islands now can be cut up into low, medium, and high. Things that are a little bit anxiety provoking, things that are somewhat, things that are very. And that's kind of where I want to have people thinking is, and as a therapist, I'm often wanting to get the work started on the lowest point on the biggest island, meaning the one most associated with functional impairment. Let's take Contamination Island. We can circle back to Perfectionism and Scrupulosity Islands once we're done with this. Let's get our flag in this thing and let's keep moving. So conceptually, that's what I'm looking at. So you may have separate hierarchies for each one of these things. Low, medium, and high. We use 0 to 7 at Rogers, but the reality is I want to know low, medium, and high. A little anxiety, somewhat, and very anxiety provoking. And we climb the ladder at that point. It's a map. Where are we going and why? I want to explain this to the kids. Now, this is an old game, the British version, the British Isles. We used to play snakes and ladders. And I remember being in America. I spent a good chunk of my childhood in Ireland. We'd come home and people would be playing a game called Shoots and Ladders. What shoots? What are you talking about? Where'd the snakes go? Point's the same. And the point of this is you roll the dice, and sometimes you just go the number that the die are cast, and then you roll again when it's your turn. Sometimes though, you roll and you happen to get to 9. And that would be fabulous because all of a sudden you get to 9, you get to climb the ladder to 31. So you make significant progress on that particular turn, which I would think of as an exposure. On the other hand, sometimes you get to 62. And if you get to 62 in this game, the snake eats you and poops you out all the way back to 19. And my point here is that sometimes exposures go great, sometimes they don't go as great. And the only way to lose this game is to stop rolling the dice. We got to figure out what happened. If it didn't go well, correct it and keep moving. That's the idea. So I'm not thinking that every single exposure is going to be perfect. It's not. Sometimes it goes not well at all. Okay, well, let's sort this out. You and me together. Let's think about it. That's what you're doing. This is not about perfectionism. It can't be. That'd be ironic for an OCD treatment. An example of a stimulus we might use. This is the Tonka truck from my childhood, which is probably weighed about 80 pounds, is made of steel. And what I'd say is I didn't keep it in ideal condition, which makes it really good as a higher end exposure. Kids love this truck. I had a cement mixer and all sorts of good stuff. But it's a little bit of risk involved in playing with this thing. So I would bring this in once we got kids used to touching things. If I have a little kid who likes trucks, wheel this thing out, take it out of my backyard and bring it into the office, and we're going to touch this because it's reinforcing the kids likes to play with this, but also B, it's more anxiety provoking than a pristine one I just took out of a box. Wouldn't be my first exposure, but this is kind of where we're going. Another example, and this could cut either way. This could be either the person with OCD who's standing waiting for the train. She's got her feet on the yellow line as a New York City kid. I know the yellow line all too well. So you want to check out where the train's coming. She's got her feet on that yellow line. She might have intrusions if she's an OCD patient that she might jump in front of the train. Not suicidal ideation, it's an important distinction, but intrusive thoughts. What if I jumped in front of the train? So this might be an exposure because she might have been standing at the other end of the platform waiting for the train and not willing to go up close because she's afraid she might jump. We've got to test this. And so we have her do this exposure, probably 1 foot on first, then 2, and have her do this. Another exposure you might have, there might be a person behind her doing exposure who might be fearful that he might push her in front of the train. He has intrusive thoughts about harming other people. What do we do there? We go down to the subway and we take every opportunity we can to stand behind people. Usually I'm the person on the yellow line, and I got my feet on the yellow line. I got my patient behind me, and we confront the fear. Because again, you do a good assessment. You recognize the person hasn't pushed 60 people in front of the train. It's a risk we're willing to take. And in fact, I'm still here, suggests I'm pretty good at making that assessment. So, got to confront the things where they live. And this is harder to do sometimes in a pandemic world. We resort sometimes to using this as a homework assignment, having parents help with this. And these days, telehealth has been able to help us with that, and I'll talk about that too. Something to keep in mind when you're treating OCD, there's really 2 main forms. Harm avoidance, where there's a specific feared consequence, and also incompleteness, or what you see in the literature is not just right OCD. So if I touch something on the left, I got to even it off by touching it on the right. There's a lot of overlap with tic. In that case, it's more of a physical feeling that, or an urge, if you will, rather than a fear. And you can treat the same way. You do ERP, but your messaging is going to be a little bit different. I want to talk about that because this is not an insubstantial subpopulation here. We're probably talking about 20 to 30% of kids with OCD have that more incompleteness. It's not, it's just icky. It's gross. I don't like it. As opposed to, I'm afraid I'm going to get sick. That incompleteness umbrella, if you will, covers that. So what I don't want to be telling that crowd is that if you do this in 5-10 minutes or so, your fear is going to come down. First of all, it's not a fear, it's discomfort. And secondly, from what we've seen, there's certainly a lot of work done on disgust and other forms of presentation that suggest that it may not come down entirely. So I don't want to oversell habituation because that may not be what we get. I'm referencing Samuel Beckett, Waiting for Godot, which is an absurdist play from the late 60s in which these two poor fellows in a dystopian hellscape sit around waiting for somebody, and he never comes. And they discuss whether he's going to come. He was going to come on Tuesday. Maybe he'll come on Thursday. And the very last line of the play, which I love, is they finally made a commitment. They realize he's not coming. And the one guy says to the other, let's go. And then the stage instruction underneath it says, they remain seated. I don't want my patients with habituation challenges waiting for habituation. I want to say that really this treatment is not about getting rid of the feeling. It's more about teaching you to be more functional in its presence. So you might actually still feel it, but you can function better. You're not going to run away. You're not going to let this thing dictate what you do. So the messaging is a little bit different. And if you're an OCD treatment provider, I think that's an important distinction. And Rasmussen and Eisen, I think, have really spent the majority of in the literature really contributing to this better understanding of OCD. It's not all one thing. Okay, so levels of care for us, and this varies according to which system you're in. We have partial hospitalization programming, which is 6 hours a day. Customarily, that stay, I'd say, is anywhere from 4 to 8 weeks, customarily around 6. It's 3 hours of individual CBT block, which is not the same thing as therapist-assisted ERP. It's really that you have opportunities to do your work. It's probably about an hour or so per day that you're going to be sitting with a therapist in one form or another doing individual CBT exercises, exposure. But the rest of the time, you're going to have to function on your own and push yourself to do some of these things, which is why it's important for us to recognize that this is not one-to-one. If a person needs a one-to-one, this may not be, our system may not be a good match. We also, in the midst of that 6 hours of programming, there's group-based work. There's an hour of education that's required for most states, and also parent university, bringing the parents in to provide psychoed and support once a week. We also have parent sessions or family sessions. I don't want to call them family therapy because it's not. It's more like, how can we get everybody rowing in the right direction, try to help this kid make some pretty big changes in their lives. The intensive outpatient is a cut down version, and a lot of times for us, it's partial hospitalization first and stepping down to intensive outpatient when they're ready. An IOP is 3 hours a day. The stay is typically shorter. In the 4-week range, there is group and education. Parent U is not part of that, in part because people have already done Parent U if they've come from internal step downs. What I would say is certainly it's a higher level of individual and opportunity to do exposure than you get in an outpatient setting, which is usually an hour, hour and a half. But it has these additional components. And I would say that, it wouldn't be the place I would start with somebody unless they were really severe. Higher levels of care are usually associated with greater severity, having prior treatment failure, either of med or of weekly CBT, or having symptoms so severe you need more coaching and more assistance. That's who we see. So we also see, I'd say the majority of our patients, probably safe bet, receiving some form of pharmacotherapy along with their intensive CBT work. I'd say almost all of those patients are on an SSRI or on clomipramine, which is a tricyclic antidepressant associated with good outcomes in OCD. But I'd say these days the SSRIs are the most common you're going to see. So in the context of this study, one thing we're going to look at, we haven't yet, is looking at how well are kids doing in the context of our treatments, either telehealth or in person, either IOP or PHP. How well are they doing if they already came in on a good dose of med? And we set those standards in that JAMA paper in 2011 that was published, looking at partial response in people who'd started med and were still symptomatic. So if you get to an optimized dose and you're on it for long enough, how well do you do relative to people who came in on an SRI but on a lower dose? So you came in on 25 milligrams of sertraline, for example. So how do our optimized patients do compared to them? How do they do compared to the handful of kids that came in with no meds? And then the sub-optimized group turns into a second group. So if you came in on 25 milligrams of sertraline, we had an opportunity during your time with us to increase your sertraline to an optimized dose. So how does that do? Those are all things we're going to look at. We think this medication background effect might be important, and it's certainly emphasized in the Rogers system, and we want to see how much difference that makes, and we'll be looking at that. But back to my telehealth versus in-person treatment, which is really where I want to spend the time today. So let's look first at length of stay. So how long were they with us? Partial hospitalization versus IOP. You see the first in-person versus telehealth. At the bottom, you see total, and you see out to the right, D equals 0.08, P equals 0.14. The D is the effect size, and the P is the significance level. What I find interesting about this is you're talking about, and this is in days. So 28 days versus 29 and a half days, basically. So it looked like telehealth was another day longer on average than in-person treatment. And that difference, even though it's very small in terms of numerically, approached significance, but wasn't statistically significant. What I'd say is I would conclude that they're getting roughly the same amount of time. When you look at it the other way, you look at partial hospitalization versus IOP, and this is not surprising. It's exactly what I told you earlier, which is the stays in partial hospitalization are longer than the stays in IOP, about a week, which makes sense. Plan that way, that the partial hospitalization patients are usually at a more severe point, and it's a lot of novelty, so they tend to hang around a little bit longer. That difference was significant. So in terms of length of stay, the partial hospitalization kids were with us longer than the IOP patients, but when it came to in-person versus telehealth across both of those groups, no difference. Okay, so let's take a peek at the outcomes. The Cybox Outcomes and the PQLESQ, broken down by in-person versus telehealth. And when I break them down further by whether they were seen in partial versus IOP, as you can see, the partial groups make sense. The partial and the numbers are exactly the same because it's a matched sample. So we had about 400 patients treated in partial in the in-person group and 409 patients treated in telehealth because they were matched on that. One of the variables we matched on. And you look at the effect size. So an effect size of 1 is pretty darn big. This is a within subjects effect size. So 1.0 is getting big. And what you see in terms of Cybox reduction, roughly a 10-point Cybox reduction, so from 25 to 15. What you see is the effect size of 1.5 is pretty good. And what you also see is a 1.4 for being seen in telehealth partial. So that's very encouraging. The PQLESQ score, so the improvement in quality of life, is comparable and also approaching very large effect. What you see in IOP, you see a little bit of it. You can squint at this one and see a difference. So the effect size for the Cybox is 1.3 versus 1.0. And we got a little bit of a difference on the quality of life improvements, a little bit lower in the telehealth IOP. And you'll see that played out a little bit more. But what I would say is overall, in terms of robustness of response, these are pretty good responses relative to the literature, relative to those studies I showed you, where we're talking, a 10-point Y-box reduction is pretty darn good in the CBT trial. And that's roughly where we're getting here, which is good. Certainly in the more so in the PHP than in the IOP, and we'll talk about that in a little bit too. So encouraging finding is comparable and encouraging is the way I would look at this. And you can see the plots, the scatter plots. You can see the and the Y box in the Cybox is our Y-axis here, and you can see the trajectories going down in the direction you want them to, because lower is better. Lower Y-box score is better. This is encouraging. When I'm looking at predictors, we had 4 predictors of Cybox scores at discharge. One was whether they got telehealth, and that was driven by the larger effect that we got in the IOP level for in-person versus telehealth. Age was a predictor, such that it was interesting because the younger kids tended to do better. Which might also be a little bit of a complicated issue because the diagnosis count goes up as you age. So is that your case is more complex because you're older, and you have more diagnoses? We'll have to play around with that. Length of stay was a predictor too. The longer you're with us, the better off you did. And I would say that age and diagnosis count also predicted PQ-LESQ. In the direction you'd expect. So the older you were, the less improvement you made in quality of life, and the more diagnoses you had at baseline, that also attenuated your outcome. But important to recognize when I'm collapsing across all of this is telehealth patients discharged with Cybox scores that were 1.25 points higher than IP patients. Remember what I said about the Cybox, 0 to 40. So we're talking about a difference between a 20 and a 21, or in this case, it was a 15 and a 16, which to me is not even clinically meaningful. It's a good paper came out, Fo et al., adult OCD, looking at can you get patients off of their medicines, and they set the criterion at less than 3 points or less on the Cybox is not even clinically meaningful. So if I get a difference of 2 or less, or 3 or less, I'm not going to make much of it clinically because the instrument is not so hypersensitive to those kinds of small changes. Well, long and the short of it is you need a bigger difference between telehealth and in person to feel like telehealth isn't getting you what you want, and we didn't see that. 1.25 overall. Pretty small difference on the Cybox. So we're looking at moderation. Looked like there might have been more benefit for girls than for boys, which we're going to have to unpack. That's not something that customarily pops out in treatment trials, and telehealth in particular. And there's lots of things to wonder about there. My guess is in our sample, we have a higher rate of comorbid ADHD in boys than we do in girls. Not that you don't see it in girls, but the preponderance of the base rate is higher. And it could be, it wouldn't surprise me, because in some ways that was the clinical decision we're making, is if you couldn't sustain attention, maybe telehealth wasn't your best bet. And so maybe this gender piece is a proxy for the effect of a specific comorbidity pattern that we're going to have to pay some attention to. So lots of fascinating things we're going to get to do with this, and we have people who are expert at the fancy math are going to help us do exactly that. Thank you to Brian Kay in advance. Some flip side, some limitations we've got to acknowledge. First thing we have to acknowledge is that 90% Caucasian sample is at issue. We have a large enough sample to look at race, ethnicity outcomes in this, because if you're talking, you just do the math. If we're talking about a sample of almost 1,300 kids, I got 130 kids who are not Caucasian, and now I can look at those subgroups and their outcomes. What I can't do, and this, I'm gonna chat about this a little bit later too. What I can't do in this sample, I can't look much at socioeconomic status, because in order to be treated in our system, largely, I wouldn't say exclusively, but largely, you need the good insurance. Who has the good insurance? The people with higher income. So we're not going to have a large sample here of folks with lower income. And we also wonder, if you think about lower income and you think about negative life events, etc., there's some pieces embedded in that we're not going to be able to get at. We also had that truncated age range. The little guys got left out of this for the most part, not completely, but for the most part. So there's still, I don't know if this applies to your run-of-the-mill 7-year-old. I certainly don't think it applies necessarily to your 7-year-old with comorbid attentional problems who's climbing the bookcase, because they weren't in this study. We wouldn't let them in. So there's other design issues that we have to think about. Now, randomization is usually an issue. If I'm looking at a treatment outcome, I want to compare it to something that's something else, and I want to randomize my sample to receive one or the other. Now, in this case, I'm looking essentially at a pandemic effect. I can't randomize people to the pandemic. That's frowned upon by the IRBs. But what I, just half jokingly, but what I would say is that you had an opportunity here to look at kids treated during the pandemic via telehealth. Nobody was treated in person, or very few were, and they weren't in this trial, in person during the pandemic, because you couldn't. So we have lack of randomization that raises some questions about a number of things, but it's an issue, and it's an ongoing issue we struggle with. We had a clinical diagnostic assessment procedure. We didn't have a heavy-handed research diagnostic procedure, which would allow us to be more precise about comorbidity. So there's some noise in there. We have self-report Cyboxes that they look comparable to the interviewer measures, but it's still an issue. I think it'll remain an issue. So and self-reports looks like they're pretty good. They're comparable to the interviewers, but there's still some noise in there too. We also have this background pharmacotherapy issue, which is not everybody came in on the same dose of medicine. Not everybody came in on medicine at all. So we have to sort that out. But I don't have a sample of 1,300 kids who are all on the same background medicine. That's not what we do. And we have lack of follow-up assessments. So these are pre-post outcomes. I don't have follows. I don't have a budget for those kinds of things, and people didn't sign up for that kind of thing. So that's going to be a gap in terms of what we can say. So let's chat about the clinical implications of all this and talk some more about what's next. Okay. So my take on it is telehealth did well here. Telehealth offers a feasible and efficacious alternative to in-person, even for pediatric OCD patients treated at a higher level of care. That was something we didn't know about before. Now we do. We have a confident conclusion here because we have a large sample. Large samples always help you make more confident conclusions, and this is, like I said, about 3 times larger than the largest study ever done. And we'll be adding to it as we go, but right now I would say that it leaves us with some confidence that this is a true effect, if you will. Looks like slightly higher discharges. I know I'm talking about on both sides of my mouth, but slightly higher discharges if you got IOP via telehealth. And we got to start thinking about what that would mean. What is it about telehealth that maybe isn't holding up as well, or we're not getting them as low as we did in person? I think there's a number of things there to be examined, and we're going to be examining that. But in general, I'd say treatment response was robust across multiple variables, and I'm pleased with that. And I think that we can conclude now confidently that telehealth offers this viable choice when travel and distance are at issue, and when the paucity of local expertise limits access to the treatment. And that second part is an interesting issue, because in pediatric OCD, it's really hard to find people who know how to do this. I, I think even adult OCD, it's hard to find people who can feel really comfortable doing cognitive behavior therapy involving exposure plus response prevention. Now you add the kid piece, and that sample of therapists who are comfortable and confident starts to get lower. And when I have less opportunity now, let's just say I don't have anybody in my community who can do this, and in this country you can find that. I may need to reach either I can go and try another form of treatment, or I can try to get the empirically supported intervention remotely. And this data would tell me that that might be a good viable strategy. If you're not anywhere near an ERP subspecialty place, you can feel pretty comfortable now, an educated guess and a good one, that telehealth would be helpful for you as well. I think we have an additional opportunity here to look at some other things, but what I would say is thus far I'm feeling pretty comfortable about that. I've been recommending that myself in clinical settings. Find somebody who do telehealth and knows what they're doing. If you don't have that in your backyard, that's going to be a perfectly viable alternative. Now, I'm aging myself. There's probably about 4 people on this call who remember The Ghost and Mrs. Muir. It was an old 60s show, and this woman living in this beautiful old Cape Ann, and she happened to recognize over time that the ship captain who died at sea, who used to own the house, still lived there. He was a benevolent soul, but he was looking out for her. But in the end, what I would say is ghosts in the basement are a good example of where telehealth can help you. We had a case, and it was one of these things that was right in the middle of the treatment. We're doing the treatment in person. And the kid had the main problem. There was some scrupulosity stuff and some fear of evil kind of stuff, and ghosts were a big issue. And so the kid was being assigned every day in person to go down to their basement and confront the ghosts. And one way or the other, they came back in the next day. I didn't get around to it. Well, we were busy. You know, there's a lot of reasons kids don't get around to the things that are hard. And then all of a sudden, a week goes by and the pandemic hits, and we pivot to telehealth. And now I've got a therapist who's talking to the kid in their living room. And the therapist comes up with a clever idea. Well, why don't we do that right now? Go to the basement, confront the ghosts. So they started to hold all of their individual session time in the basement. And then the therapist came up with something even more clever, which is move the Xbox down there. And as a kid, she loved her games. And so when they moved the Xbox to the basement, it led to a tremendous increase in time in the basement. But I'm not sure we would have gotten there had we not had those live exposures with the therapist, with the kid downstairs in the basement. So the basement time increased in part, I think, because telehealth made this easier. And there's other applications of telehealth where I could see some advantages to doing it this way. And you know, there are potential disadvantages too, but it all seems to come out in the wash outcome wise. But there's some special cases where I'd rather be in the community or be in the environment in which this is occurring, and this telehealth idea might help us do that. I think in the treatment of hoarding, which is more of an adult problem, not exclusively, but I think it's invaluable to get your eyes on the space, because their version of a clean room may not be yours. And I want to really understand what's in there. And I think this allows us to do that. We used to take Polaroids of people's houses, and now we can do fancy things like walk them through with the computer. I'm going to learn stuff by doing that I couldn't know otherwise. The main confound in this trial, the pandemic. This is New York City in the middle of the day. And I would say, this is during the pandemic, obviously. I would say as a native New Yorker, you could walk down Fifth Avenue at 5 in the morning or 4 in the morning and see it way more crowded than this. So the pandemic had a major influence. The pandemic had all sorts of effects on folks who didn't have much anxiety to begin with, maybe more on people who did. But we didn't see a huge difference in we didn't see any difference in initial severity, which kind of surprised us a little bit. But what I would say is every bit of this, if I wanted to do a pure telehealth versus in person, I probably would have randomized patients at the same time who had the opportunity to get both. That is not the circumstance we found ourselves in. So we thought, well, let's take advantage of what we can learn via this sort of stumbled upon it. And I think we stumbled upon some really important information about the efficacy of telehealth, who it works for, who it might not work for, and it raises lots of interesting questions about how else it can be deployed to help gain access to care for folks who don't have it. So where are we going next? We are expanding the telehealth evaluation, basically the same one we just did. This is pediatric OCD. We have a symposium coming up in New York next month, in which we're going to be looking at the comparison of telehealth versus in-person for adult OCD, for adult depression, and for substance abuse mental health in adults as well. All coming out of Rogers, all with very large sample sizes. I think they're going to, I know in advance that they're going to find lots of reason that telehealth can be used in those areas as well. We're looking, I think that med question is an important one. We're going to be looking at the examination of outcomes by ConMed. And then we're going to use the fancy math, machine learning, to look at outcome prediction and moderation. Basically, the computer can see patterns in the data that you can't with the human eye. So we're gonna turn this thing loose, these algorithms, and see if we can make more and more precise predictions of outcome. And then in this case, it'll be moderation of outcome to see whether there's certain people with certain patterns who respond better to one treatment than the other. That's what we're going to be looking for. And I think this issue of ongoing issue of looking at outcome by race and ethnicity, we're going to be able to do some of that in here. But the socioeconomic status issue, I think, is because of the treatment trial being done at Rogers, we have limited folks who are not from the higher levels of socioeconomic status, family income, call it what you will. And therefore, there's going to be a generalizability issue for our data to samples in which that's not the case. And I think this discussion of inclusiveness and access to care, the telehealth opens this window, and I think it really sort of pulls us forward to start thinking about this seriously. So telehealth might enable us to improve access to care, and some of that is just people who live 500 miles away, but it's not everybody. There's some other folks who don't have access to care, who don't have access to care and could be living close to the clinics that this treatment is happening. So my take-home message here is we learned a lot about telehealth, and certainly in each one of those service lines, we'll learn even more. We learned a good deal about telehealth, and we do not want this light to go out. Anyone ever seen the movie Awakenings? You might remember Robert De Niro responds beautifully to the treatment. The treatment was L-Dopa, and he responded beautifully to the treatment, but only for a short time. This was a true story from the fascinating world of Oliver Sacks. And what I'd say is that we don't want this to be temporary. It was fabulous we could use it during the pandemic. We're already seeing signs that insurance companies and states are starting to make this harder to do again. And my argument would be, wait a minute, didn't we just find out that this works, that it makes treatment more accessible? Why would we want to pull back? I think there's going to need to be some advocacy work and some lobbying done to try to make sure we're letting the data dictate what happens, not letting our own pre-existing biases or financial motives dictate what happens. And I know I sound Pollyanna-ish that wouldn't be primary, but I'm willing to stand on that rock too. Because to me, I think this is where it comes down to. What kind of world are we trying to build? So we have treatments that work. They work at lower levels of care. they work at higher levels of care. They work at the highest level of care that we saw here in partial hospitalization. They seem to work across different variables and patient characteristics and settings. We can feel confident about it because of the sample sizes and the size of the outcomes. But then it raises this question here, which is, and this is a relatively obscure movie, Elysium, in which Matt Damon, it's basically a dystopian hellscape story where Earth has been poisoned and is basically people are farming the rocks to try to get resources out of them. And all of the people of means have been moved to a satellite above Earth. And much of the riches and resources are being sent to the satellite. If you lived on the Earth, well, and you get sick, that's kind of tough for you because all of the good treatments are up on the satellite. And I remember watching this movie and thinking, wait a minute, this is supposed to be a dystopian hellscape, but what it really looks like to me is healthcare. So if you happen to have great coverage, you have access to lots of really effective treatments. If you don't, well, maybe you don't have access. I want to show you something else. This is from, oddly enough, the city of Rochester and the surround, the Finger Lakes region. I'm actually going up there next weekend to check out the foliage in a very obscure mountain cabin, which will be fun. But part of what's going on in the Finger Lakes region, I think, is happening every region in this country. When you look at socioeconomic status populations by race, ethnicity, you see an effect that's I think chilling. So SES1 and SES2. SES1 is families making $50,000 a year or less. SES2 is 100 or less, or 100 to 51. We have a 150 is SES3, 200 is SES4, and SES5 is over 250. Okay. Look what happens to diversity when you break it down this way. SES1 is very diverse, even in Rochester, which is primarily Caucasian. But what happens to diversity is it starts to go down and down and down again when you start adding in family income. And so, and then to me, I could impose on top of this, which I didn't, but I could, insurance coverage. If you have Medicaid, you're probably not in SES 3, 4, 5, and that probably means you don't have the good insurance, and that probably means you don't have access to care. And I know this from having run an outpatient unit and looking in our area that most providers in the community do not accept Medicaid. And many don't even accept any insurance. It's out of pocket. So who am I going to be able to, who can afford my treatment, frankly? And I start to look at a systemic bias that's going to affect who can get my treatment and who can't. And to me, the way I look at that is basically, if we're not part of this solution, then maybe we are the problem as a field. Maybe we're turning our eyes away from a problem that we should be able to fix. We've got to do it at the legislative level. We've got to do it at the provider level. We've got to do it at the insurance company level, but we have to do something. Otherwise, I really do think that we're perpetuating a problem, and we're inviting people to the clinics, but only some people can get in. It's a gated community, and that to me feels really uncomfortable. And I apologize for my rant. This is from Network, for those who are old movie fans, 1976, I think. This is Howard Beale, and I'll leave you to it. But I know that Howard Beale is now was being played on Broadway, and really interesting presentation. The fellow who was, I'm forgetting his name, the fellow who was in Breaking Bad, Bryan Cranston, was doing this. And sometimes it's good to get upset about these things and try to do something about them. It's a motivator. And I think we have to be motivated to do something. Time. So I'm at the Q&A point, and I think I'm almost right smack on time. 2:10, 2:09. Cool.
You are running above time, so you're doing really well, Dr. Franklin. Thank you.
All right. So I can open the floor, and I think Jamie, you're going to let me know how we're going to do that. Maybe the easiest way is for you to read and then me to attempt to answer.
Yeah, so everyone, this is the Q&A portion. And if you want to ask a question, just use the Q&A, not the chat, but the Q&A. So you can ask your questions in there. We will try to answer as many questions as we can in the time we have left. We may also, combine some similar questions. So if I see that there's similar questions, I'm going to combine them. If we don't get to your question, you can always send an email afterwards to webinars@rogersbh.org, and we will follow up with you. So one of the questions that I did want to ask here was if you could comment on the elimination of distressing obsessions. So can you comment on how we can eliminate distressing obsessions, particularly those that remain internal without compulsive behaviors beyond ruminating?
Yeah, it's a good question. And I'd say the vast majority of folks who come to us, they tell me, can you help me get rid of my obsessions? And the obsessions can cut across a wide swath of content areas. And my response is no. And they say, what? I thought you were the OCD doc. I say, I am the OCD doc, which is precisely why I'm giving you that answer. I'm not interested in getting rid of your obsessions because you are. And we know from the phenomenology of OCD, we know from Maurer, 1939, two-factor theory, his view of OCD, is that the reinforcement you get from ritualizing provides temporary relief that you later pay for. And the way I put it to patients is the more you shove this thing out the door, the more it's coming in the window. So what's my approach to this? And then patients get mad at me and they say, you telling me I need to be tormented by my obsessions forever? I say, no. I said, you might have some, but how you react to them that's part of what we're working on. So I don't want you making them go away. I don't want you pushing them out. I want you to welcome them. I want you to allow them in. And I want you to be in the position where you are okay functioning despite having intrusive, unwanted thoughts. And then what happens is when you stop reinforcing this cycle, you stop trying to get rid of it, you provide yourself an opportunity to get used to it. And when you get used to it over time, what happens to you is those things drop in their intensity first, and eventually their frequency starts to go down. Now, again, I'm agnostic to whether you have obsessions. Patients tell me all the time, I had a whole bunch of obsessions. I'm like, yeah, what did you do about it? And they're like, nothing. You told me to do nothing. Yep. And how'd that work out for you? Well, I went about my business after a few minutes. There we go. So do I need to eliminate your obsessions? No. You can have obsessions. In fact, we know from good work done by Jack Rackman, we know that if we walk into a population and we exclude folks with OCD, we start asking about obsessional content that people without OCD have experienced in the last week, guess what? It looks like a Cybox checklist. Lots of people have unwanted intrusive thoughts. Lots of people wonder if they locked their house or their car. Lots of people who are standing on the subway think, oh, what if I bumped into her? That's common. I think that's sort of the either the upside or the downside of having a functioning cortex. That's just the brain is a bucking bronco, and we know the vast majority of thoughts that everybody has are irrelevant. I don't want you to treat these as if they're especially relevant, because when you start doing that, you start to get this sort of thought rebound effect, which we know about from the lab. When you tell somebody not to think about white elephants and do everything you can to not think about them, guess what you wind up with? White elephants. You can do it for a while, but then you wind up with more of them. I don't want that. I want you to be able to have a thought about murdering your neighbor, about drowning your child, about getting contaminated and getting everybody sick and dying, the same way you might as if you're contemplating your grocery list. There's a difference between a thought and the actual occurrence. And I want to really hammer that home in my treatment. So I tell people all the time, I'm not even remotely interested in getting rid of your thoughts. The process of stopping yourself from doing that, though, might, ironically enough, decrease their frequency and intensity. Then you can function better in their presence, then you have fewer of them, then you don't care. That's a long answer, but is that an answer?
That's a great answer. Thank you. Another question that I wanted to ask as well, and I've seen coming up here in our Q&A, is, are kids with co-occurring issues such as aggression or ASD appropriate for virtual treatment?
It's a really good question. And I would say that comorbidity is the norm when it comes to the people that we see. So most of our patients will have at least one other diagnosis. The deeper dive we're doing on this data now is, does the type of diagnosis matter? And my guess is that it does. I could see depression popping out as a significant predictor of attenuated outcome and I would say attenuated outcome in general, but maybe even more to telehealth, because you're not getting that support and the ongoing contact that might help you override that. There's also another thing with depression, which is getting up and coming to the clinic, getting dressed, getting into the shower, commuting here. All of those things might be mitigated. I mean, you think about it, it's sort of a form of behavioral activation, which is an intervention we use for depression. So if you're doing this treatment in your house where you don't have to get out of bed, we try to get them out of the bed, because I don't want to do treatment with people in beds. I don't want you treating your bed like an office either. You'll never sleep again. But what I would say is the process of coming might make a difference to somebody who's depressed. Aggression, I would say it probably doesn't matter too much which form of treatment you're getting. Aggression is going to be sometimes a significant predictor. I'd also say it depends on what kind of aggression and what brings it out. So if it's only aggression when you're going to push me on my OCD, then the training you get from us as a family to figure out how to do this artfully might reduce some of that aggression. But if I have a kid who's aggressive, no matter what the setting, it might be that aggression is going to predict negative outcome. And I would also wonder whether the absence of a trip to come in, seeing the expert in person, etc., whether that's going to attenuate the outcomes. And the answer to your question is, I don't know yet, but I think I will by the time we do finish with Brian Kay and his fabulous team and really start doing a deep dive, because we're going to have enough people in this sample with these kinds of comorbid diagnoses that are going to help us figure this out. ASD, I could see that cutting either way. I could see them being more comfortable doing this in their own space. But I could also see that the downside of not having the ongoing human contact and from people who know ASD, that maybe that would attenuate outcome. And the answer is, again, fascinating as it all is, I think we're going to have better answers once we really kind of get waist deep in the big muddy with this data set.
Great. So stay tuned. More to come. We'll have more to share. Wonderful. Thank you, Dr. Franklin. You had brought up kind of families, and another question I'm seeing is, what is the role of parents during virtual treatment? Do parents need to be available during sessions, especially if they're working if we're working with younger kids?
Yep. I would say that it's going to be tailored to the kid, tailored to the family. So the answer is it depends. And I've got the flexibility in this protocol where I can do whatever I need to do. So if I have a kid who's so disorganized, he can't get online to make it to his individual session, and he wants to do the treatment, he just forgets, he's playing with his dog, he's doing his homework and loses track of time, and I've got a parent who can provide that support, then I'm going to want to involve them sort of as the executive function crew, making sure I got a kid who shows up on time. If I've got a family that's embedded deeply in the compulsive process, the reassurance families, so the kid asks 86 questions and the parents answer 86 times. I'm going to need more family time, whether it's remote or whether it's in person. It also could be, if I start thinking about this aloud, it could be that if I have a parent who needs to work, but they can actually make part of my family session or my individual session, it might be another way to import those families that need more assistance. And we can bring them in, if you will. Even if I'm treating a kid in person, I can have mom and dad. I do this all the time now. Mom and dad are remote, so they don't need to take a day off from work, but I could still get them in and they can still be educated and participate. So I think there's ways to think about that. We have maximal flexibility at Rogers, and we try to think creatively about how best to get the families in. But the families are important, and I would say that age and development matters there too. If I have a 7-year-old, I need the family the whole time. If I have a 17-year-old, parents might be glorified Uber drivers if this kid's independent, and it depends. But what I would say is I'm gonna base my decision about how much and how to involve families, whether it's tele or whether it's in person, based on the phenomenology of the OCD, based on the kid's developmental level, their readiness for change, and their demonstrated capacity to do what they need to do. If I send a kid home to do homework, comes back in, he did the homework and he added 6 things, I don't need a parent to help me with that. You know, if he comes in the next day and I say, what happened to your homework sheet? And either the dog ate the homework or he says, what homework sheet? Then I may need a parent to help with that. Not admonishing the kid, just trying to provide some scaffolding and support for them to do what needs to be done.
Yeah, so telehealth does offer some, maybe a little bit more flexibility for families, but still family component is very important.
I think
Great.
that's right.
Thank you. Another question here is, are measures continue, are we continuing to take post-treatment to assess for the differences between in-person and telehealth? Is that something that any data that we have?
You mean post-treatment or follow-up?
Yeah, so are we continuing to measure to assess the difference between in-person treatment and telehealth longitudinally?
No.
No.
And I would say if we were running a randomized controlled trial funded by the NIMH, we would absolutely do that. Every treatment trial I ever ran, went back in my days at Penn, 25 years of doing this, is we had follow-up assessments built in because of exactly the question you might think, which is, does telehealth's effects fade over time versus in person? And the answer is, in this context, I can't answer that question. What I can tell you is that the Swedes can answer the question. So you have David Maddox Coles out at in Sweden and his group, and they are in an excellent position to answer this question because they've built the follow-ups into their outcome assessments, and I think they're already seeing that treatment via remote treatment, call it what you will, is both efficacious and durable. So if I'm looking in their sample, I'm looking at those gains being maintained for the most part, not perfectly, but well, and comparably to how you might see it in person. So that gives me some confidence, but I can't answer the question in the sample because we don't have the resources and we didn't ask patients to sign up for follow-ups.
Okay. And then another question here is, why don't we see larger effect sizes for quality of life measures, given that on average, patients did very well in treatment?
I think that's a time issue. So when you look at quality of life and you think about when we ask the questions at discharge, the last day they're here. Some of these patients haven't been home. Some of these patients haven't been in school. And so in some ways, they're making a guess about how much their quality of life has improved at post-treatment because they're still kind of removed from their lives because they've been coming here. So my guess is if I did, and Maddox Coles will probably answer this question too, is do those effects increase and improve at follow-up? It wouldn't surprise me one bit if I saw better quality of life outcomes at follow-up than I see at post-treatment, because at post-treatment, they're still essentially here. And when you're here, that means you're not somewhere else. And in our case, 6 hours a day, guess where they're not? They're not in school. So we're doing some remote stuff. And how am I going to do at school? I don't know. I haven't been in school. If I send a contamination kid back to school and then they are functioning well, their quality of life measures are going to go up, but I won't see that because they're still here when we ask.
Okay, great.
Really good question. And I would say that lag is not surprising because that we've seen it in the lit in general. Even with weekly treatment, we've seen it it takes a while for those the benefits of this treatment to really be realized in real life. Because real life in some ways is, especially for us, because it's 6 hours a day, real life is on suspension until we have to get them back in.
Very true. Very true. Thank you. Another question I'm seeing here is, how do you suggest increasing compliance with telehealth when a child really doesn't want to do exposures?
Yep. Well, that's an interesting question in and of itself. How do you improve compliance when a child doesn't want to do exposure, regardless of telehealth? The telehealth piece, it might be that I need to reach out with an email. It might be I need to reach out to the parent to try to get some support around this, make sure we're doing this. But embedded in there is a question about whether the kid wants to do exposure. And if a kid doesn't want to do exposure, I don't know if it matters too much whether they're being treated tele versus in person. I'm going to be pivoting pretty quickly to every trick in the arsenal. And maybe the first one I'm going to go for is motivational interview. So a kid tells me, I don't want to do your stupid exposure, right? How about you burn in hell? Like I got that from a 13-year-old once. And my response to that, which I thought was funny, which is I'm going there anyway, but right now I've got some stuff we got to discuss. She thought that was funny. But the reality is, if you're not ready to do this treatment and you're in this treatment, you start getting back to the whole Prochaska and Clemente, readiness for change, all that stuff. And if I can't move you, you're adamant you don't want to do this treatment, I don't know if I want to be doing this treatment. If you're on the fence, if you're like, well, maybe I do, maybe I don't, I can work with that. But somebody who's actively disengaged and says there's nothing you can do to make me do this, I think it might be the wrong treatment. And I think that Alec Pollard is an expert in the cognitive behavioral treatment of OCD across the spectrum, is he would quickly pivot in that circumstance to talking about, quote, treatment interfering behavior. So what he would say is, okay, so it sounds to me like I've explained what ERP is and how it works. It seems like you're not quite convinced that you could or that you should do that. So why don't we talk about the things preventing you from doing that? Because otherwise, what I don't want you to believe is that you're getting ERP when you're not. Like I'm asking you to take this pill, if you will, and then you don't take the pill. What's the effect of the pill? I don't know, because I haven't taken the pill. And so I want to not try to shove this thing down your throat. I want to try to use, as any good MI therapist would do, is to elicit the change language from the patient. And if I can't elicit the change language from the patient, I better start wondering if this is good money after bad, and maybe it's not the right time.
Great. Thank you for that, Dr. Franklin. I think that's all the time that we have for questions. But remember, if we didn't get a chance to answer your question, please go ahead and email to webinars@rogersbh.org, and we will follow up with you. Just thank you so much, Dr. Franklin, for taking time out of your day to share with us your clinical expertise and your valuable insights. We really appreciate it. You know, collaboration is just so essential when we're helping a patient on their road to recovery. And Rogers provides services throughout a growing network of communities across the US. And we do have multidisciplinary treatment teams. We have many wonderful experts like Dr. Franklin overseeing our treatment. We'd love to partner with you. We do have outreach representatives all over the country who are looking forward to learning more about you and your services and your practices, and they're happy to answer any questions you might have. So before we conclude, I'd like to ask our presenter here, Dr. Franklin, to share a few key take-home messages on this topic with our participants, and then that will wrap us up.
Sure. I think I just skipped that slide. Let me go back. There we go. So ERP works. and it looks like it works across the whole spectrum of age, which is good. And it looks from our data like it can be delivered effectively via telehealth. We have data from outpatient already that we were feeling good about. Now we have data from IOP and PHP. So it looks like even at the higher levels of care, the treatment can be delivered effectively. There are some clinical circumstances, and we'll find out a lot more about those, where telehealth might be preferable. There are also some clinical circumstances in which in-person might be preferable. And that's the next dive we're doing. And to me, I think that telehealth may offer an opportunity to bridge the access to care gap. And I don't mean just in the context of remote care, 6-hour drive. I just did a study with Doug Woods on treatment of adult trichotillomania. And one of the things that we found is that we're looking at who's going to complete the trial versus who's not. What we found was if you had to make more than one bus transfer, as opposed to a direct line to the clinic, if you had one bus transfer in your commute, you were less likely to finish the treatment. So again, here's a person who might live 5 miles from the clinic. They don't live in 6 hours away in the Rockies, but they don't have access to care the way somebody else does because of their circumstance, because of the commute, because of they don't own a car. And telehealth might be able to get some of those folks back in. I think there's many ways we can use this that we want to be creative about, and I think we got to start pushing back against restrictions on using it, because it's a valuable tool. I'm not saying it's a panacea, but what I am saying is it's probably going to be another way to extend our reach, and I think extending our reach is what we're all trying to do.
Absolutely. We just want to help people get better. So thank you. That wraps it up, everyone. I just want to remind you of a couple things. Those of you who meet the required time commitment will be eligible for CE credits. Within the next 30 minutes, you will receive an email with a link to your personal dashboard on ce-go.com, where you will be able to access PDFs of this PowerPoint slide as a handout and complete a list of references. Those of you who met the time requirement to qualify for CE credits will need to complete the evaluation to download your CE certificate for this particular event. And if you have any questions about this, do follow up with us. Please contact support at ce-go.com. And just on behalf of everyone at Rogers, we look forward to partnering with you to help support your patients. Thank you so much, everyone. Have a great day.